I'm going to present today a study that we just published in JAMA Network. In fact, it's the second study from the same cohort. I'm going to explain a bit more. We are very interested in this study on the link between depression and pain. And when I talk about pain, it's mainly chronic refractory pain, because that's pain that we see in patients in pain clinics, and where, at least in France, but I think it's the same in the UK and in Europe overall, people are referred when chronic pain is really refractory to treatment. And so these patients really, they complain of pain. Usually it's age out of 10, and it's quite, it's really difficult because very often they have a lot of comorbidities as well. So the treatment of chronic pain is quite difficult, in fact, because there is a lot of failure, of treatment failure, and very often it's really a small percentage of patients who really are relieved by any treatment. And we can see that in our country, but we can see that in Europe. And I'm a president of the research committee at the level of the EFIC, that's the European Federation of Pain. And when we compare our data, that's exactly the same. In pain clinics, patients really, very often, they have already passed with pain failure, with treatment failure, and many adverse events. And very often they stop treatment even before treatment might be efficient. I'm thinking, for example, of antidepressants, because they consider that they have pain, but they're not depressed. And so it's very difficult to convince them to take antidepressants for a pain relief. So very often ketamine for pain, that's really the last draw. I mean, that's really the last treatment we can offer. Of course, there is RTMS, and there are other treatments as well, like lidocaine. But really, this is really an off-label drug for pain, for chronic pain. It's not in the anesthesiology world, of course, but in chronic pain, that's really the last resort. And we have done already a study, which is on the same cohort, but we followed 585 patients. And in fact, we had some patients who had just one intervention. When I say intervention, it doesn't mean just one ketamine infusion. Very often they had one ketamine infusion several days, or just for one day. So it varies. That's why we call it intervention. And and we had also patients who had several interventions of ketamine over 1 year. So in fact, we split the cohort in two. For the first paper, we really focused on the patients with one ketamine intervention. And on the second paper, the one I'm going to present today, is with several interventions, and to see the effect really of ketamine on repeated ketamine treatment on chronic pain. In the first study, we showed that there are really distinct pain relief trajectories, and it's what we are interested in pain. We really observed that patients do not react the same way with ketamine. And even with just one dose of ketamine, I think it might be the same as well for really depression. It varies a lot according to quite a number of variables, like anxiety, depression, quality of life, or even the type of pain. And in the first study, just to show you how we proceeded, so we coordinated the study in Clermont-Ferrand, in the center of France, and we collaborated with 30 pain clinics. The cohort was 585, and with just one intervention, we had data on 256 patients that we followed for 1 year. So I'm going to describe a bit more what we did, but we had telephone calls with them every month for 1 year. But in globally, they just had one ketamine intervention. These were the results of the first study with one intervention, and we managed to show that we had different phenotypes of patients, and we had patients that were quite refractory to treatment. And you see that's the top of the screen with fibromyalgia patients, while the neuropathic pain patients did much better, and they managed to go almost towards 2 out of 10 pain evaluation. So that was the first study. Then we went to the second study with several interventions, and we really focused on data that had been published in between. And also, I must say that it has been very inspiring, the discussions we had in Oxford with Rupert and with Sarah and with people and the speakers who participated. And we thought that it would be interesting to really focus on this link between depression and pain. So we know that pain and depression are often comorbid. Many chronic pain patients experience depressive symptoms, and it's very common, although it's not really described as such by your patients. Very often they would say they are anxious or stressed, not really always depressed, because it's quite a step forward to say that that is depression. And we know that both pathologies have clinical consequences and a decreased quality of life. A lot of papers have described common neurobiological elements in the central nervous system. And of course, we have observed, and we observed in the first study, that there is a concomitant decreased level of pain and depression when ketamine is used, but this is not always done systematically to check how is the level of depression and pain. On the other hand, we had ketamine that has been shown really by really a lot of people and a lot of groups now that there is this rapid antidepressant and anti-suicidal effect, especially in treatment-resistant depression. And we read a very interesting paper that had been published by Lan and Roger McIntyre in 2022, where they showed the link between how pre-treatment pain symptoms might influence the antidepressant response to ketamine in depressed patients. So that was very interesting, and it inspired us as well to go forward in this second study. So the objective of the study really was to look at the trajectories of the clinical pain trajectories that we had shown already with one ketamine infusion, but with repeated ketamine administration. And this is really a real problem, because patients, once they have started ketamine, very often they just want to go on. And in fact, they embolize the pain clinics, and it's very difficult to really get them autonomous afterwards. And we don't really know the addictive effect on the long term. There are many problems with that. So we wanted to see what was in our study, how would be the clinical pain trajectories of these patients. And on the other hand, we thought it would be interesting to look at how pre-treatment depressive or anxiety symptoms might have an effect on pain relief. So these were the two objectives. Well, there were others as well, but these are the main ones. So the methods, this cohort is a cohort of 585 patients. We followed them for 1 year. These were really only patients with chronic pain chronic pain for more than 6 months, and all these patients had either neuropathic pain, peripheral or central, fibromyalgia, CRPS, or other pain symptoms. So the same pattern, but repeated ketamine administration, and on a population of 329 patients that we followed over 1 year. We did not change the protocols that the pain clinics were using. I mean, all the pain clinics were using only, at the time, it was racemic ketamine. S-ketamine was not authorized in France yet. Now it's authorized, so we could use that, of course. But at the time, it was only racemic, the racemic form. And in fact, the way we proceeded, in fact, we had no, it was an intervention, but it was in the course of the treatment of the patient. So we did not change the protocol. There was no specific protocol. And in fact, we had quite a number of different protocols, different duration, frequency, route of administration of the drug, but mainly it was IV. And we looked at the cumulative dose of ketamine as well in milligrams. So once the patients had the first treatment, they were called at 1 week after ketamine administration, and then monthly for 1 year. So it was a lot of work, I mean, a lot of data collection, I mean, that it's on such a heterogeneous population. And so we collected data on demographics, on pain. It was mainly a pain assessment. We did as well the DN4, which is an evaluation of neuropathic pain in 4 questions. And it's very much used in France. I mean, there are other tools worldwide, like the Lance, for example, or Pain Detect in Germany. And also we looked at the depression and anxiety. And it might be where we have limitation, because we use the HADS. And I know that you mainly use the MADRS for in depression, but for clinicians, for pain treatment, very often the HADS is very easy to use and is widely used and recommended. So that's why we used it. So the results, I'm sorry for this a bit cumbersome slide, but just briefly, just to show you, we split the women and men just to see. As you see, there are many women in our group. The age is around 51. We had an heterogeneity of etiologies, but mainly we had half fibromyalgia and half all the rest of chronic pain. The DN4 that indicates if the patient is neuropathic was high. I mean, it was almost 6. That means that the patients who had neuropathic pain really had neuropathic pain. It was not just a few characteristics. The mean pain intensity, as you see, is around 7. It's what I said in the introductions. It's 7 out of 10, so it's quite high. And patients really, they really look forward to come to the pain clinic to finally get something, get the treatment. There are as well a number of pain paroxysms that we recorded. It's very interesting to look at that, because it destroys the patient's life, because very often pain occurs really briefly, like a burn or like a stab, and it's really difficult to treat, in fact, because it's very brief, but it really impacts the quality of life of the patients as well. We looked at the ketamine as well, and of course the IV route was the main route of administration. We had also subcutaneous ketamine treatment, no intranasal, because we had no form, of course, of racemic ketamine. We looked at the IV cumulative dose over 1 year. It was very difficult to choose how we would do with that. Would we use the number of interventions, or And finally we decided with the statistician to use the cumulative dose of ketamine. And as you see, when we look at the percentage of patients, well, it's quite nicely widespread, because most of them, we had around 20 to 27% in each group, with a very low dose of ketamine and higher doses of ketamine. Because in the first study, we showed that the ketamine effect was dose dependent. And so we wanted to see if the cumulative effect of ketamine would be also dose dependent. And that was a big question. We looked at the duration of treatment, and according to the pain clinic and where they were located in France, the way they were using and keeping patients inpatients was a bit different according to the different hospitals. So we had quite a number of differences, but it was not major. The interesting point was that we followed the emotional aspects as well. And as you see, the mean anxiety score was around 11, and the mean depression score was around 9. So this underlines that patients have this problem with anxiety and depression. And with anxiety, we had 50% of patients who had an anxiety score superior to 11, which means it's really anxiety. For depression, we had only, if I could say, 38% who had more than 11. So it's not all the patients who reported this problem with depression, but still it's there, and anxiety as well. And the quality of life, we followed with the SF-12, and we showed that their quality of life was very low, in fact, for all the groups and all the patients. So what did we find in this study? We reproduced the first study, and in fact, we followed the same way, looking at the statistics, and we obtained exactly the same profiles, where there are slight differences according to the percentages in each group, which is not surprising because it's a larger sample. But it's quite interesting that some patients really do quite well, and mainly they are neuropathic pain patients, and we have these fibromyalgia patients on top who really don't do well at all. And we had as well a number of interesting differences between the lowest trajectory, that we call the black one, that we call trajectory 1, and the blue one, that's trajectory 3, and quite different regarding depression, anxiety scores, and quality of life, mental and physical health. So there were differences. So in fact, we confirmed that we had different trajectories, more or less the same profiles of ketamine that we found in the same study. So it was quite reassuring that we found the same thing. We also looked at the cumulative dose of ketamine, and looking at this dose of ketamine related to the trajectory. And it's where things get a bit more interesting, because we showed that the cumulative dose of ketamine does not influence the pain trajectories. So in fact, that's something new compared to our first paper, that in fact the dose itself of ketamine might not be so important, or at least as important as we first thought it could be. We looked as well at the pain intensity depending on the baseline depression status, and the depression was the HAD, as I mentioned before. And what we showed is that the pain intensity, in fact, is really depending on the baseline depression status. The more depressed, the better the patient would be responsive to a ketamine. And in that way, we really we confirm, but reversely, what the team of Roger McIntyre found with pain and depression, but reversely, which is quite interesting. So we went a bit further, and in fact, we looked at the how depression and how the dose of ketamine might mediate pain diminution, because in the first study, our idea was that it would be dose dependent, and we never thought that depression could be the mediator of pain relief. And in fact, when we did the statistical analysis on the 321 and 29 patients, what we thought was that the pre-treatment depression symptoms do influence the analgesic effect of ketamine, and that the cumulative dose of ketamine, in fact, has no influence on, as such, on the pain diminution, and no influence either on the initial depression. But what's important is that the initial depression really is the leader and is the big mediator of pain diminution. And what we observed was that the more depressed the patient is, the greater the relief from pain would be with ketamine. So in fact, that's something intuitively, that's something we could think, well, it's normal. But it's very important in pain treatment, because when you look how people are seen when they come to the pain clinic, of course, very often they have a full pain examination, comorbidities, and so on. But the focusing on depression is something quite new, although it has been advised to look at the depressive profile of the patient. But that's something new that we would need really a systematic evaluation of of depression in the chronic pain patients. And that's, I would say, the main message of the paper, and something that we need to apply in pain clinics. We often do the HAD score, of course, but maybe we should be better for psychiatric assessment as well, perhaps. I mean, not all pain clinics do have a psychologist or a psychiatrist, and that's something that could be interesting in the future. Just briefly, we had all the expected adverse events. Even, of course, after the first treatment or after each treatment, we always observe a number of described adverse events. We looked specifically at uropathy as well, because there has been a number of papers, especially when people have a repetition of ketamine treatment. But it was quite, it was quite expected what we had, and we had nothing dramatic with the patients. Of course, we had limitations in the study, because as I mentioned, it was the HADS that might not be the best tool. Of course, there is no placebo group because it was a real world study, and we cannot say that we had no placebo effect of ketamine, I mean, of course, because this has not been evaluated. We haven't done specifically each time after each infusion the neurocognitive performance, and that would be something as well very interesting. And as I mentioned before, it was with racemic ketamine, and obviously the S-ketamine that has a different pharmacological profile might lead to other results as well, but something that we are very interested in as well. So in conclusion, this study, in fact, has opened new avenues for research. We answered a few questions that we were asking ourselves for quite a number of years, I would say, but we still are not very certain about the addictive properties of ketamine in chronic pain. And it's very difficult to untangle the anti-hyperalgesic, dissociative, the affective components of ketamine effect on pain and on depression. We showed that ketamine is very useful as an anti-hyperalgesic drug via the NMDA mechanism, but we also stressed that it might not be a good drug for all patients with pain, and we need maybe to phenotype and genotype better the patients. And it opened as well a clinical aspect that is important. That's the what I mentioned before, that's to evaluate the depressive symptoms systematically in chronic pain patients. So I think I covered more or less the paper, and I'd be quite pleased to reply to your question. And this is my team on the left. It's not complete, and the setting in Clermont, where we do our research in the ward. Thank you for your attention.
Great. Thank you very much indeed, Giselle. That's a marvelous sort of clinical study. As you say, very real world, you know, it just seems immensely believable. So that's really nice, and you know, encourage people to put their questions in the chat or raise a hand. Can I perhaps start just by looking at going back to some of your slides and just understanding particular. Well, I have my first question is about the number of days of treatment. Could we look at that slide and just understand what you mean by that? Because of course the duration of
this one. No, what is it? Wait a second. No, that's the next one. Yeah. Well, yeah, it's that was. I think that's one of the problems of real life studies. That means that in fact we accumulated the days of the duration of ketamine administration, and that's the last lines that you mentioned, Rupert. Is that right?
What I'm after is obviously when we use it for depression, we tend to treat for 40 minutes or an hour or something like that. But I'm right in thinking that when it's used for pain, the durations are much longer. So you're basically dividing the number of hours by 24 or...
No, in fact, it's the same. I mean, when you have just one administration, that's very often it's 0.5 milligram per kilo over 45 minutes.
Ah, perfect. So this is the number of, when you say the number of days, what you mean is the number of treatments that are administered.
That's right. But as I mentioned, usually it's what we do. That's just one infusion, 45 minutes. But in many, it's not everywhere the same because there is no consensus.
Sure.
And in fact, there are clinics where you have 4 days with 0.5 milligram per kilo per day. So that's 4 days where you have, in fact, 4 infusions.
Over 4 days, once a day.
Over 4 days. And then the patient goes away, comes back 1 month later or 2 months later.
Okay.
And it's very heterogeneous because, in fact, how to treat all that, because you have, I think we had 18 different protocols. So we looked at the number of the number of days patients have been administered over 1 year. And it's where you see less than 6 days, 7 to 9 days, 10 to 10. That's the mean, in fact, of the how many patients have been receiving the ketamine, but cumulated, because otherwise you cannot deal with that.
Yeah, so roughly 40% of people are receiving more than 10 infusions in a year.
That's right. Yeah.
I get it. I get it.
And in fact, it's where it was really a question by the editor as well, because it's of course it's a real life study, so it's not it's very heterogeneous.
Yeah.
And how can you? And that's something we are looking a bit more now, because in fact we showed that the cumulative dose in fact is not very important in our study. I mean, the number of milligrams is not important, but we think that maybe it's the repetition of a certain amount of ketamine over the year that might, in fact, provide pain relief.
So did you,
Rather,
forgive me if I've forgotten that, and you did show this, but did you look at that, the duration of the treatments, if you like, or the number of days of treatment? Did that influence the pain scores? Was that different in the different trajectories?
No, it didn't. It did not, and it did not influence the trajectories either.
No. Okay.
You see, and it's where it might be interesting, because I think when you look at the action of ketamine pharmacologically, it acts on NMDA receptors, and maybe you just need an optimal amount of ketamine to go and block the NMDA receptors, rather than a mass of ketamine arriving to the central nervous system. And it's where we're working at the moment.
I mean, the most sort of strongest take-home message that I get from this, which is just so relevant to us, is that, you know, ketamine's not very good for fibromyalgia.
No, that's the point. I think it's, but in England, I don't think you use it much for fibromyalgia, which is a good point, because I went to the BPS last year, and in fact, it's more for neuropathic pain. But in France and in a number of European countries, it's used for, I would say, everything.
Well, but that's why it's so helpful, is because if you know, it's much more helpful in the sense to know who not to treat.
That's
and
right.
To say, actually, you know, we don't think it's going to be very helpful, but it'd be really helpful to see if there are people in the audience who disagree with you on a
that would be interesting. Yeah.
So let me invite people to respond to that. And anyone who's keen on treating fibromyalgia with ketamine. Tiago, I knew I could rely on you.
Hello. I found this disturbing that fibromyalgia does not respond to ketamine, because I have a clinic. I use ketamine for fibromyalgia, but not only ketamine. That maybe the gap, because I use usually with lidocaine 2 mg per kilo.
Yeah, exactly. Well, I think that makes the difference, I think. Yeah.
And I use for several kinds of pain, chronic pain, but I always do ketamine with lidocaine. Maybe that's the confounding factor.
Yeah.
And we have good results in lower back pain, in fibromyalgia, in phantom limb pain, all those kinds of hard to treat or untreatable, I cannot say untreatable, pain, and they go well. Maybe if I do just lidocaine without ketamine, I don't know, but I think I just feel, because I don't have a strong data on this, that both of medicines work synergistically.
It's interesting, because in fact, I did not show all that because it's a bit, it might not be so interesting, but a lot of fibromyalgia patients, they take a number of drugs, but not as many as the neuropathic pain patients in our cohort, you see. So maybe when you give fibromyalgia patients ketamine plus lidocaine, I think it might be better in a way than ketamine on its own. In my experience, lidocaine seems to work better than ketamine in fibromyalgia as well. But in France, at least in France, I mean, it's very often the GPs don't know what to do with the fibromyalgia patients, and they refer them to the pain clinics. And when they arrive at the pain clinic, they say they've tried everything already, tramadol, opiates, and so on. And it's very difficult to wean them from treatments, in fact. And we start, in fact, from scratch, and we say, okay, we decrease your treatment and we'll do ketamine. And it very often doesn't work. And the patient comes back, and we try ketamine plus lidocaine or lidocaine on its own. And it's a very, I think it's a very difficult population as well.
Maybe that's the point, because I always use lidocaine with ketamine, even for mood disorders, when things are not going the way I want, like reducing anxiety, reducing depression, I use lidocaine as well with ketamine, and I get good results. But it's hard for me to say anything beyond I feel that I got good results.
Feeling. That's right. Yeah.
Data is just my feeling, my clinical practice. But for sure, I've treated patients with fibromyalgia with ketamine and lidocaine in the same infusion.
Yeah, do you want to say what sort of mechanistic sort of what the just mechanistic justification for the lidocaine might be in that population?
Yeah, the thing that I may have come up with is because lidocaine is a strong blocker for sodium channels, as well as some mood disorder, some mood stabilizers, anticonvulsants, mood stabilizer. They also block sodium channels, but they are not as strong as lidocaine or any other local anesthetics, because local anesthetics you completely block, and with anticonvulsant, anti-seizure medications, they are not so strong. They don't have this affinity for the receptor, so we cannot do local anesthesia with some carbamazepine. We cannot do this. We can do it with lidocaine. So when we do lidocaine IV, what I understand that I'm doing is blocking sodium channels and doing some kind of anti-seizure or blocking transmission in pain fibers, and reducing the adrenergic sympathetic tone in the patient with anxiety and racing thoughts and those kind of mood.
I think it might be why it works maybe better with this combination. You act on the NMDA receptors and probably on many other receptors with ketamine, with the serotonergic, I mean, lots of receptors, even the opioid receptors. And on the other side, with lidocaine, you go with sodium channels and maybe more the sensory fibers. Could be interesting, yeah.
And that's really interesting. And I'm sorry that you've got such an echo that seems to have suddenly started, Giselle, on your
Yeah, really. I'm sorry.
Don't know why that's happened, because it was fine when you were talking before. Okay. Yeah. Other questions from other people? We've got one in the chat here. Yeah. So that's saying the same thing. Do the clinical sites in France base their infusion schedules on the patient's symptoms, or simply follow a schedule without regard to pain scores?
Yeah. Well, that's a very important question, because in fact there is no consensus. We tried to do a consensus. Last year we published in European Journal of Pain a Delphi study with these 30 centers, where we showed that in fact everybody has each hospital has its own protocol, in fact, but most protocols are 0.5 milligram per kilo per day. Most of them do that, just one inpatient admission in the morning, they leave in the evening, and that's it. And it's not according to a pain score. So it's really something which is systematic. In some other hospitals, they give the ketamine over several days, so they keep inpatient for 3 or 4 days. And interestingly, we discussed that, Rupert, last year together. When they leave, they, instead of having the patients coming back 2 months later, they give them a prescription of dextromethorphan in order to continue the effect of on the NMDA receptor. And in fact, practically seem to work, because patients don't come back or don't call for another admission after 2 or 3 months, or even further down, and at least it's oral rather than IV.
And they're taking dextromethorphan how often?
they take 30 milligram 3 times a day.
33 times a day.
Yeah, 30 milligrams. So that's 90 milligrams per day. We have a pharmaceutical form in syrup as well, and some patients prefer that. It's cough syrup, in fact, and so very often they prefer that. But it's quite heterogeneous. But the baseline for most of the pain clinics is 0.5 milligram per kilo. And it's really systematic this way, but and they try now not to keep the patients during the night, because a lot of centers had these patients admitted and even keep them 2 days. But now there is problems with reimbursement because it's an off-label drug that is suspected to have, of course, as we mentioned, and we all know, addictive effects and neuropathy consequences when you repeat too often. So there is a problem with the health agencies now for the reimbursement. So in order to keep within the official lines, that's the way people do it now. But it works quite well. I think now things with the arrival of the S-ketamine, this might change things as well around, which is not so, because people don't know not well how to use S-ketamine for chronic pain. They know that for anesthesiology or even in depression, but there are very few studies on S-ketamine and pain, in fact.
May I contribute with this? I only use S-ketamine IV in Brazil. So everything I told you is with S-ketamine IV.
So that's very interesting, because I'm sure that there are some differences regarding the pharmacodynamic effects on pain for the two enantiomers. Maybe. I mean, that's never been shown in any case.
I think, I mean, there's recently a paper published by Janssen about their experience with S-ketamine, their long-term experience with the SUSTAIN-3 study, and I'm just having a look at the dosing frequency, and essentially about a third to a half of people are taking it at least every other week, and quite a lot, about a third of people or quarter of people are taking it every week. So that's
use a lot. Yeah,
it is a lot, and obviously it's a lot more. You know, it's about 4 times as often as the use for pain that you've described, and you used a charming word which I will never be able to forget, but you said that it embolized your clinic.
Yeah,
so
it's an embol. I don't know if it's like a thrombus, honestly, because there are so many fibromyalgia patients coming in requiring treatment because everything has failed, and especially these fibromyalgia patients who had COVID as well. So that's double burden for them. And in fact, once they see that ketamine might work a bit and might give them a bit of relief, it's very difficult for them to leave the place. And it's very difficult to say, well, the first line of treatment is not drug. The first line of treatment for fibromyalgia patient is exercise. I mean, it has been recognized by EULA and by the American Society of Rheumatology. And you're really in the corner there. Difficult.
I mean, we could just chat now, and if anybody does have questions, please butt in. Can I ask, do you think fibromyalgia patients with depression do better, or do they just tend not to do well at all? Can you say that from your data?
Yeah, that's a good question. I mean, we had the observation was that fibromyalgia patients were basically more depressed. And in fact, when we extract these fibromyalgia patients, the worst, I would say, the ones who are the most depressed, they seem to do better, in fact, than fibromyalgia patients that are less depressive symptoms. So that might be a hope for these fibromyalgia or neuropathic pain patients. When depression is high, maybe the treatment might be worth trying, ketamine, for these kind of patients. So we're working on these subgroups now to see if we could have proposed recommendations for specific subgroups within the types of pain. So that's interesting, yeah. So in fact, our idea is more now that the ketamine might have an action on the prefrontal cortex, and then have this action on depression and then pain, rather than on the amygdala or other aspects. Because what's interesting in the combination of pain and depression is that there are very few studies that looked at the way of the pathologies, of the comorbidities. And it seems there has been a recent meta-analysis showing that pain patients developing depression are not the same than depressive patients developing pain. So in fact, that means that centrally the areas in the brain, in this meta-analysis, they show that for some patients, when you start with pain, it's more the amygdala that is really the problem, while in depression it might be more the prefrontal cortex. And in our case, that would lead us to say that maybe ketamine acts on the prefrontal cortex, on depression, and then on pain. You see, that's where it leads us, but it's just an hypothesis. But I think it could be interesting for treatment, and maybe to apply for other treatments as well.
I have a couple of questions, if you don't mind, because it's such an interesting work. I'm also sorry that I arrived a bit late today. But so just to clarify, and I'm sorry if I missed it, the HADS, did you administer only a baseline or also throughout the year?
Well, we did on the baseline, and we followed the patients as well with the HADS at each time until for 1 year.
Because I think in the paper, of course, it was focused on the pain.
Yeah, well, it was asked by the editor to focus on this, because the original paper was really, we had all these correlations all along as well. So they wanted really to have a very straightforward message for treatment, just because, as I mentioned before, we had so many protocols and different doses that it was very complicated. So the idea was to focus from the baseline. So basically, when you have a patient coming to the clinic, is depressed, or you do the HADS, you think he's depressed or anxious, or then if he's very depressed, that's a good chance for you to give him ketamine so that he could be relieved from pain, you see. And at the same time, in this patient, they were doing much better for depression as well.
It would, I guess, I mean, from a psychiatrist's point of view, it would be interesting to see if the mood follow the same trajectory as the pain score across the year, right? If the fibromyalgia remains the same.
It does, but within the fibromyalgia group, in fact, we had well, basically they were more depressed than all the other people, but we had very few that were extremely depressed, you see, on the top scale. So in fact, although we had 585, well, in this study it was 329, but we had very few of these top really sick patients. In fact, you see, I think we had maybe 30 or something like that, so that we could really have a real conclusion for that.
And also, if you don't mind me asking, I think on your article, you have part of your table that also like reported concomitant medication.
Yes.
And, was there like any difference, for example, in patients that receive antidepressants that, you know, we may assume they've been diagnosed with depression in the past, so they were aware of those condition, or it was pretty much independent from that?
Well, that's a good question indeed, because very often the patients, pain patients, are a bit reluctant to talk about depression. And as I mentioned, you ask them if already they have an antidepressant. It's very difficult very few of them would admit that they had depression, but very often they say, it has been given to me because of pain, you see? And yes, it's a bit difficult in the pain clinic to sort out what's I would not say what's the truth, but what's the reality. Was it given to them for depression, or was it given for pain? And in fact, very often there are so many things to do. It takes already 1 hour to be on the practical side. And I think we're not good enough now to, we have to improve on the depression aspect to really focus more, because the HADS is not done everywhere systematically in all pain clinics, you see? And many of them have these pain medications that they had for a long time, but the adherence to the treatment, you cannot be really sure, because very often they switched off and don't want to take anything anymore because it doesn't work. And it's very difficult to be sure how much they take, because the prescription very often does not reflect what they really take. You see? So that's a bit complicated, but an interesting point, we are doing more stats on the all cohort, the 585, and you know, in one of the previous sessions of the journal club, we were talking about the gender differences, and in fact, in our group, there is no difference in the male and female. I mean, so it's quite for pain, nor for depression. But on the chronic and repeated treatment with ketamine. But something interesting is that when we give just one intervention, so that's what what is on the screen now. When we give just one intervention, it seems that males do better and respond better to ketamine than women. And I was wondering, I was looking at the review by, I think it was Roger McIntyre, can't remember, it was a systematic review on sex and gender in depression with ketamine. And I think they say they could not really conclude because there are positive or negative answers to that. So that's another way, because fibromyalgia affects mainly women. So you see, so we have a bias in our population as well. So we want to give it further down to see how ketamine might act differently in males and females.
Thank you.
You were sort of slightly apologetic about not using the MADRS. I don't think you should be. I think you know what psychiatrists do when they do a MADRS is they ask the patients how they feel, and then they fill in the MADRS. Whereas, you know, with the HADS, the patient does it themselves. So you just leave out the psychiatrist out of that loop. So I'm not sure it makes a huge difference.
Is there another questionnaire or something else we could use instead of HADS?
HADS probably okay. I mean, we use PHQ-9 or the QIDS. Those are the sort of the other ones, the patient reported outcome measures that are easy to
Yeah.
use. I don't know, Sarah, if you're looking as if you're pensive.
Yeah, no, I agree. I think the MADRS especially maybe was very informative, especially for the serotoninergic drugs. So not necessarily captures what you're looking for. Another one could be the Hamilton Depressive Scale, something that is clinician rated, I guess. But yeah, otherwise I think the quiz is another gold standard for us, right? Is it not? But yeah,
I think the important thing is to use something, you know, and it's always going to be easier to get the patients to fill it in. So that's always going to be a better for a cohort study to something that's patient and, you know, completed. If you can get the patients to do it.
It actually made me think if even from a psychiatric clinic should include some questionnaires on pain. Maybe
there's a four questions.
Yeah, I think it's both ways. That's interesting. Yeah, because I'm sure. I mean, this comorbidity is so frequent. I mean, it's the problem we have is to identify depressive symptoms in pain patients. Of course, you've got the pain patient that comes and say, I'm depressed, and they can verbalize it. Of course, we have that. But very often you have patients who don't complain so much about their mental state. And in fact, even when you say we give you antidepressants for your pain treatment, they refuse to take it. And so I think we have, as clinicians, to work a lot on trying to convince them or bring that with time, maybe, to try to, because we all know that antidepressants for 2 days doesn't work.
Giselle, I want to see if we can wheedle a question out of one other audience member before we finish, but if not, then we're going to stop at this point. But have we got one question, I'm sure that somebody here has got a burning question that they want to ask Giselle.
I'm a bit on an outsider, as I said last time.
No, not at all.
On pain.
Not anymore.
But it's nice. No, it's nice.
Well, I tried. Giselle, thank you very much. Lovely study. And really, really interesting data. Thank you for your presentation. Congratulations to your team on, you know, it's big sample, and I think that gives it a real credibility. So and thank you for keeping it simple. I know that always helps. That always helps. And we look forward to hearing more about the further analyses from this big study. I think it's interesting. And look forward to seeing everybody else at our next event. Sarah, can you say anything about that? What we've got next?
Yes, so it will be Simon Kung from Mayo Clinic who's going to kick off the next year of the Journal Club, and we will be restarting on September 12th. Same time, same link.
Okay, great.
Okay.
All right, thank you all.
Okay. Have a nice summer.
Bye.
Bye.